So awesome. Can you hear me okay? Great. Welcome, everyone. Good afternoon. It's incredible that after 35 years of being a resident and faculty here, I can still get lost. So, I've never been able to figure out these numbers, but I was that way for a while, so my apologies. So welcome and good afternoon, and welcome to our, I can't believe it, our 8th annual Richard T. Moxley Rare Disease Lectureship. And do we have the slides available? I had a few intro slides. Were you given them? No? Okay, they were supposed to be up. It's okay if they're not. So welcome to the Richard T. Moxley III Rare Disease Lectureship in Neurology. This lectureship honors our esteemed colleague and dear friend, Dr. Richard Moxley, or Mox as many of us know him. Dr. Moxley joined our faculty in 1974, bringing exceptional training from the NIH, Harvard, and George Washington University in neurology, endocrinology, and exercise physiology. And over his remarkable 45-year career, Mox was a trailblazing academic who held the Helen Arrestine Irving Fine Professorship from 1966 until his retirement in 2017. He and his wife Joan then moved to Maryland to be closer to his family, from where I believe he is joining us today. We had a lovely dinner last night at Next Door Bar and Grill. And it was a great dinner and celebration, and we spent some time with him. And throughout his career, Dr. Moxley held numerous leader positions within our department and the medical center. He was instrumental in establishing and maintaining the university's Clinical and Translational Science Institute, and in developing one of the best examples of bedside translation, frankly, in all of medicine. Mox seamlessly integrated patient care, world-class research, and mentorship. His particular passion was myotonic dystrophy, where he led Rochester's NIH-funded Wellstone Muscular Dystrophy Center for 15 years. His remarkable insights and research visions established the foundation for today's revolutionary advances we are seeing across all of neuromuscular medicine. He pioneered the concept of clinical trial readiness, preparing our research teams to execute the transformative work we see today. Beyond his academic brilliance, those who know Mox appreciate his warmth, Southern charm, and his genuine kindness. He remains a devoted sports enthusiast and a family man who continues to care deeply about the people and program he helped establish. We're honored to celebrate his legacy through this lectureship and delighted to have him with us here today. I know you're out there, Mox. The Moxley Lectureship has consistently showcased exceptional minds in rare disease research, and our distinguished previous speakers started with Dr. Mandel and a great number of speakers, and last year we had Dr. Robert Griggs as a lectureship. And today is another esteemed faculty member and friend, Dr. Emma Ciafaloni, and we are thrilled to have Dr. Herman introduce Dr. Ciafaloni for the lectureship. So thank you.
So good afternoon. It's my true honor to be able to introduce Dr. Ciafaloni as the 8th annual Richard T. Moxley III Rare Disease Lecturer. So Dr. Ciafaloni completed her medical school and neurology training in Milan. She undertook research fellowships at both Columbia and Duke, and then did further neurology training in a neuromuscular medicine fellowship at Duke. And then after a short stint on faculty at Duke, we were really fortunate to, with the help of Rabita Will and others, to be able to pry away from Duke and bring her here to Rochester in 2002. And she's had a truly illustrious career. She is today a tenured professor of neurology, pediatrics, obstetrics, and gynecology. She is the Robert C. and Rosalind H. Professor in Experimental Therapeutics of Neurologic Disease. She is the Associate Chair for Research in our department and is the Director of Pediatric Neuromuscular here at URMC. And really, a defining theme of Dr. Ciafaloni's career has been a focus on rare diseases. Her early work, working with Billy DeMauro and Alan Roses, focused on mitochondrial disorders and Duchenne Muscular Dystrophy. And then here at University of Rochester, she's built upon the groundbreaking work of Birch Greggs, Dick Moxley, and Sri Pandey in pediatric neuromuscular disorders. She's really developed one of the leading contemporary environments for pediatric neuromuscular disorders, a phenomenal multidisciplinary care environment. She's been at the leading edge of experimental therapeutics in pediatric neuromuscular diseases, focusing on Duchenne and SMA, and is a widely sought-after thought leader. But beyond all those accomplishments, she's truly one of the most phenomenal, outstanding faculty members any Department of Neurology could hope to have and for us to be able to associate with. She's an outstanding clinician, educator, researcher, and scholar. But the one thing I'd like to highlight is the impact she's had as a mentor. Sitting in this room are several of the mentees of Dr. Ciafaloni. They are now emerging leaders in pediatric neuromuscular diseases. And if you look across the landscape of pediatric neuromuscular medicine in the United States at other institutions, you will see many future and emerging leaders who've been mentored by Emma. So without further ado, I very much look forward to your presentation today, Emma, entitled Improving the Lives of Children with Duchenne and SMA Through Newborn Screening, Milestones and Remaining Challenges. Welcome, Emma.
Well, thank you so much, David and Bob, for inviting me to give the Moxley Lecture in Rare Diseases. I feel incredibly humbled and obviously very honored, although I have received so many rewarding just by working here over the past 20 plus years, but this is one more reward that I really feel very blessed about. And for so many years in the past year since Mox retired, I remember myself saying, oh, I really wish Mox was here to see this. And so what I hope to do with this lecture today is really to showcase what his team, the Rochester team, has been doing in the past few years, and to highlight some milestones in the field, and really making it a gift to him. And I would like to do this by highlighting from the angle of what newborn screening program can really do to change outcomes in children with rare diseases. So that's going to be the particular angle. So, and since it's not moving. Oh, it's moving. Okay. It's not moving here. Okay. So since I have the podium, I also would like to take the opportunity to highlight the Rochester neuromuscular pediatric team guiding principle that has really guided us and the whole team over the past several years. And gratitude is the first one, to really be able to practice during this time of drug discovery and life-changing medications, and really with the best possible team and with children who are so incredibly resilient and really teach us gratitude every day. Also, you know, opportunity. I think that we always learn from early lesson and things that maybe didn't quite work as perfectly as they could have been, but how can we act very quickly and take those opportunities to do better and to learn fast? And then our university motto, Meliora, so there is always space for improvement. And I think that the major implementing improvement in our team has really come by having a very diverse team and having young people, because young people are super smart and old people tend to do things the same way. So the input that we have from our mentees is say, sure, we should do that. And then a strong commitment to advocacy, which in our case has been done at the level of the state and federal to really advocate for easier access to high-cost complex drugs for our children, but also to really advocate for implementation of newborn screening in rare neuromuscular diseases. And ultimately, legacy. I'm not going to be shy during this lecture to say that, we feel very proud of the Rochester way of doing things, and the Rochester team. So I'm going to show off a little bit, but really it's about the team. And I think that legacy really means that it's not about a certain individual or what we do, but it's really about what we build in terms of infrastructure and programs and what we leave behind, so that it's going to be long-lasting. And I always tell my team, if I drop that tomorrow, I know that this program is going to be very strong and it's only going to get better. And I think that this sense of legacy, we really owe it to the giants that come before us, such as Moxley and Birch and Rabbit-Will and here and so many others. And I think that that really is a guiding star for whatever we do in clinic. So I cannot see moving here, so maybe. So I would like to start by celebrating for Moxley a very important milestone that happened just last week. So Moxley, this is a little gift for you. We are actually celebrating a major milestone. We dosed the 50th baby with gene therapy last week. So this includes for Duchenne and SMA across the clinics and the clinical trials. This is our upcoming star, Dr. Lee, who treated this baby, and not because we're counting or we are a little bit competitive, but a day of life too. Just pause for a moment, and received then gene therapy last week, but she had elevated antibodies. This is a baby that was destined to have SMA type 1. And the worst form of spinal muscular atrophy. I also would like to highlight that currently we are the only program at the University of Rochester that does in vivo gene therapy. So this milestone is particularly significant, and we hope that it's going to help newer programs that are hopefully going to start soon. But what I would like to really start telling you is, how did we get here? And rather than leave this at the end, I really need to bring this out first, because everything that I'm going to show you from now on is really due to the outstanding multidisciplinary team that we have built here. And we are blessed to have mentored and recruited Dr. Lee, Dr. McKenzie, and Dr. Brown, that have really made possible such a comprehensive plan, especially with newborn screening, which, as you know, is a 24/7 program. So it can be the game of just one person. Our physical therapist, clinical evaluator, our nurses and MPs, without whom we couldn't do any of this. Our genetic counselor, which is one of the smartest person I know, and that's been so crucial in really moving the program forward. And so many others listed here, including Erin Collins and the pharmacy team. Treating children with these very high-cost complex drugs takes a lot of medical expertise, but it also takes an incredible amount of administrative infrastructure, because these are cost like $3.5 million, but this really affects the timing of treatment. So these pieces of the puzzle to make it happen are all equally important in my view. So I think that SMA changed everything, and the old model of neuromuscular disease, it really was based on clinical diagnosis with a significant diagnostic delay, like in all rare diseases, and really a multidisciplinary approach that was really predominantly centered on supportive care, and there were really no disease-modifying treatment prior to 2016. And then all of a sudden, new treatment became available, and the new model really shifted to a different type of diagnosis that is done through newborn screening and prenatal testing that require delivery of the most novel gene-based therapy in a timely fashion. So really, we became almost like stroke doctor, like, you know, we're on 24/7 and time is muscle, and really requiring not only a new clinical infrastructure to manage drugs that can cause death, acute liver failure, and really a serious safety profile, but also new administrative infrastructure because of the high cost and the complexity to access the drugs. So the fact that these drugs are FDA approved doesn't really ensure access in a timely fashion. And that's what we have concentrated a lot of our effort over the past few years. SMA, just to remind everyone, it's anterior horn cells and is the leading genetic cause of infant death. Definitely a rare disease, 1 in 10,000. But I also want to point to you the timeline that the gene and the cause for SMA was discovered in 1995. So 30 years later, I'm going to show you how we now have changed the way we treat this disease. And of course, anterior horn cells are non-regenerating cells, and that has, I think, in this particular case, really helped the case of treatment. So the SMN1 gene is disrupted in this disease and no longer able to produce the SMN protein, and that's what's caused disease. But interestingly, the SMN2 gene, which is kind of a backup gene, has only a little one pair mutation in exon 7. And I want to show you this because our therapeutic strategies actually focus on, number one, to replace the full SMN gene, which we can actually do with AAV vectors, because the full length gene is actually able to be inserted in AAV transfer. In AAV vector, unlike in Duchenne. But also the other strategic therapeutic options is to actually increase inclusion of exon 7 in the SMN2 gene to increase the production of a full-length SMN2 protein. And these are the other true splice-modifying drugs that are now available. And I also want to say that the number of copy of the SMN2 gene is what modulates the severity of the phenotype. And just to remind you that, you know, type 1 is the most severe form. These are children that have never be able to accomplish sitting independently or walking. They will never be able to breathe or eat independently. And they usually die before their first birthday. And type 2 and 3 are less severe, and they have more copies of the SMN2 copy, but nevertheless, very serious disease with loss of even those milestones that are reached early in life, they're eventually lost over time. And so the other thing that was a perfect storm in terms of developing new drugs for SMA has been the incredibly well-described natural history, especially for type 1. And I want to remind that this is one of those principles that Bert and Moxley and Dr. Tawil always thought and say, you really need strong natural data in rare diseases before you can even think about clinical trials. And in SMA, this has been the perfect example. And by the way, natural history from SMA comes from the PNCR, which our Neuromuscular Data Coordination Center has been managed since the onset for decades. So again, the Rochester influence here. But here you can see that children with SMA type 1, they have 8% survival at 20 months. So it's a very catastrophic and rapidly progressive disease. And these are the 3 treatments, nusinersen and risdiplam, which are really indicated for all ages. and the gene therapy on azemnogene abeparvovec, which is only indicated for children younger than 2 years old. But what I want to emphasize is that while the pivotal trials for all three of these medications unequivocally met their primary outcome with incredible p-values in symptomatic children, subsequent trials demonstrated that if you actually start any of these medication at the pre-symptomatic stage, so before these children actually develop symptoms, the outcome was incredibly better. And in neurology, we usually really stay away from the word cure, but I think that some of the things that we have witnessed after newborn screening, I think that's pretty close to a cure, and I hope to show you that. So unequivocally, we had very strong trial data, and I think that that really helps the case of the perfect advocating data for newborn screening. So another major milestone has been that currently since January of 2024, because of this medication and the strong trials data, 100% of newborn babies that are born in the US are all universally screened. Although the SMA was added to the RASP in 2018 in February, New York State was one of the first states that actually started screening. It took about 6 years for the all 50 states to take on, and this is how it goes for newborn screening. It takes quite a long time because it's not a law or a mandate when it's recommended by the RASP, and states have different policies and timeline to actually implement universal screening. And so here we went, and we started preparing for this probably 12 months ahead. We knew that these new drugs were actually coming, which helped us when we had our first newborn screening referral, and Sam was born 5 days after gene therapy for SMA was approved. How lucky is that? And he was born with 3 copies, so destined to have SMA type 2, meaning never be able to walk independently, able to sit, and then eventually probably having to recur to respiratory and feeding support. So he received gene therapy at 4 weeks without any complication at the pre-symptomatic stage, and no side effects. This was our first one. And now he's 6-year-old. He stays very active. He's on no medications, and he's very active in ice skating, gymnastics, basketball. And every time he comes to clinic, I think that Nicole and Kate and I are really trying very hard to find anything wrong with this kid. And I think that so far we have pretty much failed. And not only he achieved these milestones that are unexpected for SMA2, but he achieved all the milestones except for jumping. He was a little bit late in jumping, but he achieved them at the regular, normally developing children age. And here is him at 13 months. So achieving the ability to walk, which we have never seen in these kids before. Now, we also, the other thing that we never had in neuromuscular is its parents sending us videos of children doing things. So this is a whole new world, and our phones are packed with videos now. So, but that was the first case, and I remember celebrating and say, okay, we got this, we did well. It was 3 to 4 weeks, he's doing great, no complications, right? Little did we know that many lessons were to come, and every subsequent child really taught us significant lessons that just because we have newborn screening and a leveling playing field, what happens from the day we get the call for a positive to when we treat, there are a lot of things that need to fall into place, and many possible barriers and delays to treatment. Some are medical and some are non-medical, and we really had to work and learn very fast of how to do better to avoid those type of delays. So this is a case of Bien. He was born at 34 weeks and 6 days, so a little premature. tested positive with 2 copies of SMN2, so destined to have the type 1, the most severe form. And we evaluated him at day of life 9. He had reflexes, he had a CHOP, which is a motor outcome scale in children. 40 out of 64 is great for that age, and his compound muscle action potential was very robust at that point, and we knew that we needed to treat as soon as possible because it was actually destined to develop type 1. Sure enough, insurance gave us a denial because they were concerned about gestational age, and their definition for their policy was that you cannot treat before 40 weeks of gestational age. And so we ended up having to wait to treat, and at day of life 28, at that point, he had lost his reflexes, his CHOP was down to 24 points, his ulnar and peroneal CMAPs were decreased by 75%. So we knew that we had lost the window of opportunity despite newborn screening. But we turned this great disappointment into advocacy. And so we really wanted to highlight the case that prematurity is not a barrier but an advantage. And so we published this case and making a strong point that really gestational age of 40 weeks is really full term, and that for kids that are at risk of such a severe, rapidly progressive disease, there is really no reason to treat as early as possible at 37 and 1 day for sure, unless there are other medical issues. And so we published these, and actually, this has now become the norm that people actually try to induce early if you have prenatal knowledge that they are carrying a baby with SMA, to actually really, induce early and treat as early as possible. And this is part of the nervousness come from old data that has not really been proven, because we need to give 1 milligram per kilogram of prednisone from the day before dosing with gene therapy for about 3 months. And there are old data that dexamethasone, which is really used for prematurity lung disease, there was some risk of developmental delay that really has never been really proved. And so this was a big accomplishment, because now the policies have changed and we're able to treat much earlier. The other thing is that is medical, is sometimes that these babies have positive AAV9, which is the vector where the gene therapy is. They're positive because they're transplacentally inherited from the mother, so we cannot treat until they are clear out, which sometimes takes some weeks. And so obviously, this can make a huge difference from moving from pre-symptomatic to symptomatic, but there has been incredible improvement in actually accessing bridge treatment with other splice modifier, either risdiplam or nusinersen, to the point that now we can get, for example, risdiplam for free as a bridge medication until we are able to treat with gene therapy. And that's actually the 50th baby that I show you. That's exactly what we did, so that they really have access to one of the treatment as soon as possible, regardless of antibodies. And then all of us in peds neuromuscular had to become a pathologist and a cardiologist, because this is a very high toxicity risk for the liver of an immunogenic reaction to the vector. And so, but sometimes in babies, especially in young babies, GGT is very elevated. That doesn't mean that they have liver disease and that we cannot dose, but we were really left to make very difficult decision of risking and making sure that the GGT was just a spoof through prematurity, or just the fact that GGT in infants there are no really good normal ranges, and go ahead and proceed with dosing, taking the risk that, liver, or having to really screen them for true liver disease with the timely efficiency that was very novel in our field. But we have now learned that we tend to ignore GGT unless it comes with other liver abnormality. There were ethics problems that we have encountered when we had the first baby that was reported to us as the closest newborn screening center. But the baby belonged to the Mennonite community, so they didn't have a phone. So we didn't even know. In fact, I remember Bo and I thinking about driving down to Penn and knocking on the door and say, you know, we need to talk to you. Ultimately, rather than call the police to kind of reach the family, we were able to reach the midwife in the Mennonite community, and that was really very, very helpful. The family decided to go see first in Dr. Carson, which really specialized in this special community there. But unfortunately, the parents refused treatment, and this was a baby with 2 copies, so destined to develop SMA1. So what would you do? And I can tell you the countries in Europe, when I was during my sabbatical in Oxford, they will call the court immediately, and they will call the judge and say, okay, we need to treat this baby. So we discussed it among our team. We talked with Shinto. You know, the beauty of this place, we have so many wiser people say, what do we do here? You know, to really get the court involved or the police and going down that route, the disadvantage was, well, how are we going to create a trust with this family? Because, you know, we dose them, but then there is a 3 months of very intense follow-up, and it doesn't end there, right? We really need to follow this baby for the rest of its life. So at the end, we compromised, and we kept talking with the family with the help of the Mennonite community. And fortunately, we were able to treat the baby at day of life 30. Unfortunately, by that time, he was symptomatic. So still early, right, you know, but nonetheless, a delay. And then a new phenomenon, we do have newborn screening, but now if you go to OBGYN, you will be offered more and more prenatal genetic testing. Those panels have grown exponentially, and SMA is now pretty much on all of these prenatal screening tests. And so OBGYN frequently identify family, women that carry babies with SMA. And so this gives us an extreme opportunity to treat hyper-fast, induce early, and get ready very early. The problem that we have also learned is some of these OBGYN practice, they do the prenatal screening, they identify that the baby is a carrier of SMA, and then they stop there, rather than, reach out immediately to a neuromuscular treating center so that we can actually get all the ducks in a row and recommend early delivery and treat super fast. So this is something that also Dr. Lee has been extremely effective in bringing up, and we're about to publish actually some of the cases that have been treated through this mechanism and what a difference this makes. So how have we done over the years in time to treatment? So we were able to create a consortium of all the newborn screening centers in New York State, all of them. And I think that, again, the merit goes to Dr. Lee, who has been able to really bring all the neuromuscular pediatric group across the state to really collect the data. And you can see here that since we started screening in 2018, we can say that in this analysis, infants screened in later years were treated faster. There was a statistically significant difference in mean age of treatment. And there was the least variability in treatment age in the year 2024, with most infants now in 2024 treated before 20 days of life. So things are going very well. And again, I want to highlight that this is for the all center, newborn screening center across the state. Rochester, we have been treating between 3 and 26 days in 24, but more recently, our record has been 2 days. Not that we want to brag about that. And for the 2 copies baby, between 2 and 9 days. I also want to say that for SMA, we have treated the highest number of newborn screening referral for SMA across the whole state, and it's been not uncommon for us to treat babies from the east part of the states and from the city. But newborn screening is a great equalizer, supposedly, and really leveling the playing field, because you avoid the socio-demographic diagnostic delay, and that is a good start, but that doesn't equate to equal access to treatment? What happened after the newborn screening? And so we were particularly concerned about this point to prove that, especially in a disease where you have treatment that costs 3.5 million and they're very hard to access, does this universal playing field translate in equal opportunity for early treatment? So, and when I talk about access, I think, you know, people there might live in a homeless shelters, or they don't have, during the pandemic, they couldn't get a birth certificate on time. And those are all pieces that we need in order to order the drug. Language barrier, transportation. So one way to study this problem, and this is work that is ongoing now, again by Dr. Lee, is newborn screening really allow us more equity in healthcare? And the area deprivation index is a way to look at this. So, for example, for New York State, you can see the red area are the one with most disadvantaged groups versus the blue area, which, as you can see, is very much concentrated in the east part, is the least disadvantaged group. And so the ADI is really, it's a proxy measure for social risk factors that can impact health outcome. So we thought that we could use this methodology in collaboration with the health department to review all the cases treated in New York State since the implementation of newborn screening. And what we, although the numbers were only 53, so we couldn't really apply statistical analysis for significant differences, you can see that at the national level and at the state level, we found no apparent trends identified on the visual spread, so suggesting that access to first modality treatment is quicker than in the past across all ADI index. We're going to continue to monitor this because I think that this is a very important case to demonstrate that really the full success of newborn screening. It's important to remember the newborn screening program, there is a lot of funding spent for pilots studies, lots of grants and a lot of financial support. But once the test is proved effective, the infrastructure for the clinical and the access to treatment, there is no funding or money for that. The case is referred to the clinics, and then you do your best. We have changed that because we recently were able to actually receive award for a 1.9 DoD grant. Again, Dr. Lee, who should probably really give this talk. And so we are now going to be able to actually, that is for Duchenne newborn screening, but really it's the first time they're successfully getting grant funding to study what happened after. So I want to leave you with this real story. These are the two siblings, Owen and Adeline. Owen is 11, was diagnosed clinically at age 22 months and started Spinraza at age 3. And Adeline, who's now 5 years old, was diagnosed prenatally and through newborn screening and was treated with gene therapy at 6 weeks at the pre-symptomatic stage. And this is Owen. And I want to tell you, not this past clinic visit, but the visit before, I walk into the room and I ask, Owen, how are things going? How are you feeling? Because he gets Spinraza. And they say, I feel very joyful. So going back to that theme, these kids are very articulated, but you know, and going back to the theme that these kids are resilient, they really teach us gratitude. And here is Owen. So, and so Owen had reached the ability to sit independently, but never walk. He still maintained an FVC of 72. He breathes on his own. He's never been hospitalized. He's eating on his own. And he has actually gained some points on the Hammersmith, which is a scale we use in SMA type 2 over the years with Spinraza. And he excelled in school. And this is what he can do at age 11, after 8 years of treatment. This is part of the Hammersmith scale and the ability to sit up independently. And I know that for some not used to our diseases, this might be even maybe a little bit painful, but actually there is pride and a little smile because he can still sit independently. And we also need to do this to maintain access to Spinraza. So, and here is his sister, who's now 5 years old and was treated with gene therapy. And again, you know, I don't know that we like the term cure in neurology. We are neurologists after all. But to me, this is the closest thing I've seen in my whole career. So Moxley, I hope that this made your day. So moving on to Duchenne, the incredible case of SMA is like the dream case, right? Okay, all the pieces of the puzzle fell into place, a dramatic change in outcome for these children. Can we aspire to do the same for Duchenne muscular dystrophy, which is a much different, very different disease because significant progress has been made. The case of Duchenne presents unique challenges, most of all the fact that transducing skeletal muscle it's a huge challenge. It requires the highest dose of gene therapy in the history of gene therapy. And muscle, unlike anterior horn cells, it is a regenerating tissue with fibers that are multinucleated. And that is just one of the many challenges. The other challenge is the dystrophin gene is the biggest, largest gene in the human. And so there is no way that we can put the full length of the gene into AAV vector, which currently is the only vector available in clinical human trials. And while we wait for larger or better strategy for vector to allow a full length of dystrophin, we are actually using mini or microdystrophin construct that supposedly have an effect in muscle membrane stabilization, but nevertheless, they're not the full-length gene, unlike in SMA. So this is the therapeutic landscape in Duchenne, which has been incredible. We went from having prednisone and never met a drug rep in my life to now, 8 FDA approved drug, 4 exon skipping drugs that are approved for all ages. So that's right there, medication that you could use in an infant identified through newborn screening, although these are applicable only to about 30% of children because these are mutation specific. We have gene therapy, AAV-mediated gene therapy with microdystrophin, 1 drug only approved, and it's approved for 4 and older. And I'm not gonna go get into the big saga that as of Monday night, there has been full stop of delivery of the FDA-approved gene therapy Elevidys for a number of reasons, including a third death in the overall gene therapy program in an adult limb-girdle patient, 51 years old in wheelchair, and 2 deaths, which we already knew in Duchenne kids that were no longer ambulatory and which a much higher weight. So initially there was a pause for non-ambulatory Duchenne, and then due to a number of also politically influenced issue, the stop has been called as of Monday night. And then obviously we have non-gene-based treatment that aren't inflammatory, antifibrotic, and you can see the indication by age. So we have a number of drugs that are eligible for very young kids from 0 to 3. And yet, and this is one of my favorite paper because Moxley is the senior author and I'm the first author, and this was really Moxley convincing me that we needed to study this. And this has served us so well in the advocacy to implement newborn screening because we showed through the MD StarNet surveillance grant that there was a significant, almost 2.5 years delay with the mean age of diagnosis still at about 5. And if you look at Black and Hispanic, that delay is even larger of all the diagnostic milestones. So And we, because of that paper, we started a very strong campaign, a national task force for early identification of childhood neuromuscular disorder. And despite the many efforts by the CDC, the AMA, and a campaign that was targeted to both the family and the public, the parents, and the pediatrician, we were able to analyze the data in a subsequent cohort of 221 males that were born later, 2000 to 2015, and we were stuck right at 5 years mean age of diagnosis, so there has been no progress in that sense. And again, you know, all the milestone you can see in the second column, those are non-Hispanic Black, years of difference in terms of first CK, first neuromuscular visit, and diagnostic confirmation. So not much progress there. And this has really been used as one of the strongest, it's one of the most cited paper when we go in front of committees at the federal and state level to advocate for newborn screening in Duchenne, is this: we're not making a difference. We have treatment available, and in the United States, we still make kids. We had a kid just a few months ago that showed up undiagnosed with Duchenne muscular dystrophy at age 7, okay? This is not a big diagnostic zebra, Duchenne. It should be much easier than that. But one of the biggest challenges is that where is the sweet spot for skeletal muscle treatment? We know that muscle fiber injury starts even before birth. All these babies have high CK at birth. The muscle fibers are going to start breaking down because of the lack of dystrophin from day one, and it's only going to get worse. But at first, in the first stage, that injury is also counteracted by regeneration capability of the skeletal muscle, so almost like it's still a reversible process. The second phase is once the muscle is replaced by fat and connective tissue, there is no gene therapy or drug that's going to bring that muscle back. And so on one hand, you know, you want to intervene as quickly as possible, which might be good for some antifibrotic mechanism of action medication. But for gene therapy doesn't transduce satellite cells. So there is a big concern of dilution effect over time, and having to redose, which currently we don't have the capability because of the immune response. And also, again, transducing skeletal muscle takes massive doses of AAV, and so the potential toxicity is very, very high, but much higher in older, heavier kids. So ideally, we would like to treat at a much younger age if we could figure out how to transduce the satellite cells, which many scientists are actually working on right now. And so the other problem with newborn screening for Duchenne, that unlike SMA, which is a DNA-based newborn screening, which there is only sickle SCID that is DNA-based, so that is a no-brainer. When the test is reported, you know that the diagnosis is correct and is genetically proven. For Duchenne, it's really a screening because we screen for CK. So it's very sensitive, but not very specific. And one of the dogma of newborn screening is that you shouldn't discover diseases for which there is no treatment. So with CK, you're going to uncover a large number of non-Duchenne. So if your CK come back below the cutoff, you're fine, but if it's above the cutoff, then you're referred to a neuromuscular newborn screening center and you do genetic testing. You can screen positive for Duchenne Becker, you can screen negative, or, and this is about half of the people that are going to be identified with high CK, they might end up with the screen positive for other neuromuscular disorder, or a number of VUS where you never know what they have and why their CK are high. This is a big stumbling block for advocating for newborn screening because it's really not what we should be doing with newborn screening to discover non-treatable diseases. And the New York State pilot reached the goal to really say, okay, this is doable. The CKMM has been approved by FDA. It works. Because the pilot will occur during COVID, obviously the number of babies screened, almost 37,000, was well below what we had originally planned for. But nevertheless, there were 42 infants referred because of high CK, and 4 were identified with Duchenne Becker. So as you can see here, we also had 22 newborns with VUS. So this is still an unresolved challenge for in Duchenne, because we cannot do DNA-based screening for this particular disorder. Nevertheless, we have learned an incredible amount of data about CK cutoff, and the false positive is now down to 1%. But these are the many challenges still for Duchenne. Obviously, we are very strong advocate that we feel strongly that it should go on the RASP. But with Duchenne, the other big challenge is that once you have a mutation, it's very hard, it's not a perfect science to predict the phenotype. As you know, we have Duchenne, we have Becker, and we have everything we've seen. With SMA, if you have SMN1 deletion, you're gonna have SMA, 100%. With Duchenne, those mutations, the correlation, genotype-phenotype correlation is very tricky. And as you reverse and start from checking for mutation and try to predict the phenotype, we're gonna start seeing mutations that we have never seen before, right? Because so far we have gone from a symptomatic child and testing. So when we discover mutation, sometimes we get a lot of referral, Jordan knows, from OBGYN, people that got screened and that have this thing in it, and they've never been described before, and we don't know if they're gonna develop Duchenne or Becker or anything at all. So we're gonna have a lot more muscle biopsy or RNA sequencing to do. This program, if it ever is gonna be implemented, is gonna keep us extremely, extremely busy with this type of challenging. And then, of course, the amount of work for the clinic to actually very, very carefully evaluate these babies. You know, there is this story that babies in Duchenne, they're really fine until 2.5, right? But the story is probably not so true, that if you actually evaluate them with the Bailey scale, which by the way takes probably an hour and a half, which probably is not going to generate a lot of RVU, and nobody covers through grants. But we're going to need to follow this baby just like that to say, okay, what does symptomatic means in Duchenne? You know, unlike SMA, where we have a pretty good understanding. And again, you know, we have corticosteroid. I'm very sorry to say, and I know Moxley don't take this, but steroids in Duchenne, they are a blessing and a curse, okay? There is basically no drug treatment that has the efficacy that the fluticasone prednisone has had in Duchenne in terms of clinical efficacy. Prolonged ambulation by 6 years, delay in cardiomyopathy, delay in the respiratory insufficiency, they blow it out of the water. And they come with horrendous side effects, okay? So they are a blessing and a curse. The problem is you can't give steroids in a 3 days old baby, okay? Nevertheless, I think that identifying babies early will give the time to really catch them at 2 rather than at 7, when it's clearly that opportunity has been lost, or even for corticosteroids. And then, you know, better dealing with this liver toxicity, which right now we're in the midst of this big trouble with the gene therapy being pulled. So the other thing is really the philosophy of newborn screening. What do the public and family really think? You know, because society has changed dramatically since 1968, when Williams and Youngner created the criteria for newborn screening. And there is plenty of literature that really says that most family especially that had babies identified clinically by clinical diagnosis and newborn screening through the many pilots that have occurred over the year, they feel strongly that yes, there is an advantage and that they will like newborn screening. And there is strong support for newborn screening from both parents and patients. And in healthy babies, over 80% of parents want to be told about conditions detected by newborn screening, if they could be treated especially. Baby Detect, the doctor survey where I spent my year of sabbatical in England, is running 100 genes newborn screening in Belgium, and it had a 95% uptake. These are all treatable diseases, including many rare diseases. So the society is clearly saying, yes, we want to know, we want this. And this is also very interesting because when we ask the perception of benefit and risk, these were a question posed to caregiver, what is the preference regarding newborn screening for Duchenne muscular dystrophy? And when they were asking, if you see the number in blue is things that were perceived as benefit, there are things such as improved psychological support, enabling reproductive planning, enabling financial planning, and access to clinical trials, which definitely is not in the Wilson and Jagner criteria. That's an anathema, but I think that society is changing. And really, psychological distress and impact on the parent-child relationship were early argument against identifying diseases that you cannot treat right away in infancy is really not very relevant for caregivers. But again, when you pose the question, a screening program for Duchenne muscular dystrophy should only identify individuals who have a disease-modifying therapy or a clinical trial available. Let's say, should we just screen for the ones that are eligible for exon skipping, right? Which you could start at day 3. Well, caregivers, 70% says, no, absolutely no. We find advantage even if there is a drug that is not really given that early. But when you, on the right-hand side, if you ask healthcare providers, they're still very much split between agreement and disagreement. So this is the old mentality, the newborn screening, unless you have something to give right away, you shouldn't really be doing it. And so my question and my argument, and many, but many others don't see it this way, is that although the Wilson and Jagner criteria have definitely stood the test of time, I also think that the society has dramatically changed from 1968, and that it's probably time to revise this criteria and to maybe consider when we consider children outcome through newborn screening is not just drug, is not just the outcome of having a drug, but it's really the overall outcome. Are these children given a better chance to have a better outcome, as defined in many different ways, including access to trials, time to really get used to, we're going to start steroids at 2, and those type of decisions. So maybe time to modernize the system, and I will say definitely yes. So what's the state of the newborn screening for Duchenne currently? Duchenne was nominated to the RASP, did not move forward the first time. We did a lot of advocacy based on the data that I just showed you, and eventually was approved for evidence-based review. It underwent a full review. It was supposed to be voted on by the Advisory Committee on Heritable Disorder in Newborns and Children in May. The committee was disbanded by the current administration in April. So we are left in limbo because there is no current mechanism to new condition going on the RASP, unless we go straight to JFK with our package, which we are not told that's the way to go right now. But that's where we stand. So we are in limbo. But the interesting thing that states, they can go their own way. So currently Ohio has been screening since April. They've already identified a few. I know that at least one baby that was identified and went on exon skipping at 6 months of age. New York, the governor signed and approved in October of 2023. We're still waiting for money to get started, and then a few other states. So I think that what we're going to see is states starting to go their own way while we wait for the next step through the RASP. So in conclusion, I want to say that clearly I hope I show you that there has been unprecedented progress in how we care for SMA. Probably SMA has spoiled us. We now have Duchenne with unique challenges and opportunities that will keep us very busy in a very good way for, I would say, at least 10 years, probably more. So for the young people in the audience, please consider taking out these challenges in skeletal muscle. There has never been, in my opinion, a better time to be a neuromuscular neurologist, and certainly, again, humbly, no better place than Rochester to be a neuromuscular neurologist. And I do want to conclude with some picture. This girl in your left and on the right has SMA type 1. So if that is believable. And I want to leave you also with, I will encourage all of you, but especially the young people and the old people, try to do what we do with joy and find joy on what we do. And I have to tell you, Moxley, that I just remember the way you walk into the room to see a patient really showed that positive, energetic, enthusiastic attitude that say, we're here to try to make a difference for you, kiddo. So we try to follow your step, Moxley. So thank you very much, and thank you for showing up. Thank you, and I'll take any question or any comment. I don't know if Moxley's on.
That was a wonderful presentation. So just a couple of questions, not knowing the landscape really well. So with the SMA, you didn't seem to find differences in sort of timing of treatment depending on that sort of deprivation index. But are we at a point now where sort of pediatricians can screen and prescribe Dystrophy as a bridge to gene therapy so that we really...
No, we can. None of these treatments are prescribable by pediatrician. One of every policy I know of require a neuromuscular specialist to prescribe all 3 drugs for SMA.
Isn't that the potential equalizer, though?
No, because the pediatrician have absolutely no infrastructure. They don't have Erin Collins. They don't have our pharmacy. They don't have Mike Rava that writes single letter agreement for a 3.5 million drug. Pediatrician, they're barely staying afloat with their now. So I don't, and in fact, you know, we have episode where pediatricians are called with a baby that's screen positive for SMA, and they tell the family, oh, this is a deadly disease. I'm sorry, this is going to be very bad. So they're still even unaware of, you know, what's going on. So I think it will be, for Duchenne, the way to go until we have newborn screening will really, and we try to push this, is for pediatrician to have a very low threshold to screen for CK, for example, at the 30 months well child, and just ask a simple question. Do you notice any delay or any, you know, in jumping or keeping up with peer? And do that CK that costs $5. And once the CK is high, everybody's going to come to us and we'll diagnose. But in countries like Italy or China, all babies that go to pre-K are screened for CK, and that's what their age of diagnosis is much lower because of incidental high CK. But here in the country of free spending and MRI for everyone in the ED with back pain, if a kid comes to the emergency room throwing up, our BMP panel does not have a CK there, unfortunately, because that would really catch a lot of Duchenne at the pre-symptomatic. But yes, Gretchen.
Interesting that Ohio has instituted the Duchenne screening. Is this because they have a strong patient advocacy group? What do you think the state level determinants are of that getting through the state and getting funded?
Okay, many factors. Ohio also had a pilot before the New York pilot, so they had the infrastructure. They probably had Jerry Mandel. They probably, you know, that probably helped. But at the end of the day, it's about the money. It's about the money. I mean, our governor signed, and, you know, is the state budget and when the money can be actually arrive to the health department lab. But for example, a disease like Krabbe disease, right? New York State screened for Krabbe disease, which is still quite controversial. You probably know better than me. Why? Because a famous football guy said, well, we need to screen for Krabbe, and we started doing it. So advocacy from someone famous can work, money. It's so variable. It's really very variable. Yes, Birch.
So I think Jerry Mandel's gene therapy was first tried in limb-girdle dystrophy, and in fact was successful. So we are sometimes finding limb-girdles sort of accidentally when you're looking for Duchenne. Are they going to get treated?
Well, limb-girdle muscular dystrophy right now is a bit in hot waters. There was a death in that limb-girdle gene therapy at 51 years old that just died. So I don't know how that approval is going to go. So I think that there was hope to have an approval gene therapy, but personally, I don't think we're going to have gene therapy for limb-girdle, at least in the current state. I think that that amount of vector for people of 70 kilos and above with so much connective tissue that, yes, you know, we transduce fat cell, but the amount of vector the liver is going to see, I think we're going to see that the safety benefit risk is still not in the right place. I hope I'm going to be wrong. But I think that our best chance is to find a better generation gene therapy with a better immunosuppressive regimen. I really think we should use sirolimus and prednisone, not just prednisone, and do it in the really young. And I think that's, again, we need newborn screening for that. And go even lower. We just took on a clinical trials for intrathecal gene therapy for Duchenne that we're gonna do in 2 to 4 years old, but it's gonna be delivered intrathecally to try to avoid the hit to the liver. So that's gonna be interesting. There are many other products that I think that now that with stronger suppression regimen, I think they're gonna have a better chance. And also with vector, still AAV vector, but they have been tweaked to decrease the immunogenicity from the liver. So I think there is definitely hope, but I think that Duchenne is leading, not limb-girdle. I think size is a big problem. Yes, Michelle.
I've done another presentation about SMA that following newborn screening, the incidence of SMA decreased, and you're much about that.
No, you're right. I think we all grew up in medical school with the 1 in 10,000. There are a couple of factors. For example, New York State, which is the second or third highest birth prevalence is also going down, right? We're now down to 200,000 in New York State, and we used to be around 250,000. But remember those prenatal panel, and depending where you are geographically, especially on the East Coast, those panels the uptake has increased significantly. Now, of course, the law for termination of pregnancy have changed, so that's also thrown in the mix. But I think the family access prenatal screening more than in the past, and they're gonna decide to, terminate pregnancy, at least in states where that is still an option. But yeah, so far, and after newborn screening, you can take 1 or 2 years, because, it goes a little bit like this, like the referral, you have to probably take 5 to 10 years to really come out with a better prevalence. But it seems like it's going down. Yeah.
It can also be family planning. If you know your child is Duchenne, maybe consider before you get pregnant and whether you're waiting for 3 or 5.
Yeah, I think that one of the arguments is at least to have access to the information. I think that if you talk with epidemiology, newborn screening, definitely, prenatal, that's not part of newborn screening, what you're supposed to do. I also tell you that, like the family, I show you the 2 siblings. The family was very happy to have another child, no matter what. Of course, they knew there was gene therapy, but that to me showed an incredible amount of courage. I think that the family story is like, wow. And I'm so glad that, the sister is doing so well and Owen loves her, but it's like a story, say, wow, you're really brave, Yes.
That was so great. I mean, because one time you do everything so well. And one thing you've done so well is the sabbatical. As the chair, I'm always advocating for people who are eligible for sabbaticals. I want to do everything I can to support them and try to create a sabbatical. I just wonder if you reflect on what you did and how you actually structured it, because I think it was so instrumental.
Yes.
So much of what you're doing now and where you're at with the program and national and international
Yeah, thank you. I think that, again, I have to thank Birch, because Birch, for years, it will occasionally come to my office and say, so when are you taking your sabbatical? And I had some personal reasons for feeling a little mixed about that. And then I had the fact that it was just me. And newborn screening was coming, and if I was somewhere in England, who will take care of these kids? So while Birch was telling you need to take a sabbatical, I hired Bo, Sam McKenzie, and Bree. And actually, Bree wasn't yet in the picture, but when Bo and Sam, I say, I'm going, you got this. And I left them here with all the really high safety risk gene therapy trials and all the babies, and guess what? They did way better than I could have never done. So, which proved that we had a good thing in place. But yes, a sabbatical has so many positives. First of all, it refreshes your brain. We think that we read papers, but no, we work all the time. So you have time to read, to be creative, to really think also about what is it that you want to do? What's your legacy, you know? I am not a translational researcher, and I don't write big grants. You know, we have giants of that. But at the end, we all have one goal, right? To change, to make, you know, our patients' life better. How can I contribute to that with my own skills and passion, which might be that different than, you know, other people? And so that's what the 6 months in Oxford gave me. And I'm always glad to talk with anybody that wants to brainstorm about a sabbatical. I was on a point also where I kind of thought I knew about humans, that it's not like working in a lab, humans are complicated, but I had encountered, you know, with the COVID, many disappointing aspects, right? Families that they want gene therapy, they don't ask a single question about safety or side effect, but they will not vaccinate for anything. And that is you know, I thought I knew, and I really need to take a moment here to think. So yes, extremely positive. Take it, you're gonna come back re-energized and with some ideas, and really refocus and say, what is it that I can delegate to some people that can do this better, and what can I really focus? And like right now, I used to do a lot of clinical trials. I have a passion for clinical trials. Now I only take the most risky gene therapy trials that keep me up at night, because that's what I like to do. And the younger kids, I don't take other things that say, you know, plenty of people might do that. So, and also, you know, the collaboration. I want to tell you this, when I was in Oxford, we had a meeting in Liège. People from all over the world, Israel, Saudi Arabia, Ukraine came, and we had a workshop about how to implement newborn screening for SMA. And the people from Ukraine that were getting bombed in the hospital, they were there, and when we were having our workshop, they say, you know, we're feeling so sorry that it took us so long to start newborn screening for SMA. And our mind went, you know, you're in the middle of a war. And in the United States, at that point, we only have 30 states that were screening for SMA. That's really put in perspective how these diseases and how are really managed in the rest of the world, and what it means to do the best and access, you know, programs that are helpful for patients. And we think that, well, we're in the United States, but what about the rest of the world? So I thought that that was a great lesson of humility, and also the resilience of people who really care about rare diseases in circumstances that you will think, you know, it's impossible, but they did it. So yes, take a sabbatical. But make sure that you have team. That's the other thing that I love. Moxley is probably, I hope he's still listening. I know Moxley is a big sport, and I don't know anything about sports, but I do know that research and best clinical care is a team sport. And if you don't create the best possible team, you're not going to go very far. I cannot tell you how many pediatric neuromuscular programs in this country currently are based on one faculty that can do this. One faculty. So think about it. Except for maybe CHOP, Boston, Rochester. Yeah, many programs, if that one faculty decide to do something else, they're done. So mentoring is the key, mentoring the next generation. So we've been extremely lucky here. Thank you.